We welcome you all to the 28th webinar of IAPWC Goa. So as we all know that we have been running a series on PCOD, which is a very common disorder in young ladies right now. So in the same series, after having a gynecologist and a nutritionist, we are now having physiotherapist and after that a dermatologist. So today we have dermatology in PCOD as our topic. So which is again a problem which is seen majorly in young girls. The acne can be really daunting. So I would want our dermatologist, Dr. Agneta, to throw some light on it as to what exactly can be done by them to get them into a management stage. I would like to ask Dr. Kathleen, who's the host for the day, to start the webinar. And we have the question and answer by Dr. Rashmi and vote of thanks by Dr. Parul today. So, Dr. Kathleen, can you please start?
A very good afternoon to one and all. Thank you, Dr. Smaranika, for giving me the opportunity to host today's webinar. I, Dr. Kathleen Barreto, would like to welcome you all on behalf of IAP Women's Cell Goa for the series of webinars on PCOD. The earlier webinars gave us an insight on PCOD from the viewpoint of a gynecologist, a nutritionist, and a physiotherapist. For today's webinar, we will learn about skin issues in PCOD, which brings us to our today's topic, dermatology in PCOD. PCOD is a hormonal disorder that affects women in their reproductive age, causing weight gain, skin changes, among others. As we all know, our outward appearance is so very important for our confidence. So managing the symptoms, be it through medicine, diet, exercise, or taking care of one's appearance is so important to attain the most benefit of treatment. It gives me immense pleasure to introduce our speaker for today's webinar, Dr. Agneta Kamath. Dr. Agneta Kamath has completed her MBBS from Goa Medical College and then done her post-graduation in dermatology from the same. She was a consultant at Hospicio Hospital Margao from 2015 to 2018 and was a secretary of IADVKL Goa branch for 2 years. She is currently having her own private practice in Margao. I welcome you, ma'am. I now request Dr. Agneta to take over.
Thank you, Dr. Kathleen. I'd like to check if I'm audible. Can
Yes,
anyone
doctor,
tell me?
you're audible. You're audible.
Okay. So today I am Dr. Agneta Kamath and a practicing skin specialist. Today I'm glad that I could speak on a topic which is very, very near dear to me because I am also one of the patients suffering from PCOD. Though I did not get many of the manifestation, but yes, I have seen it closely as I have been a patient. So that actually drew my interest more. And when Dr. Kathleen asked me that, do you want to speak on something of PCOD in dermatology, which I've never done, this is my first time, I was excited and I quickly said yes, although I was driving and she was asking me on the phone. I said, yes, yes, I would do it. So I was that excited and I hope I'm able to, give you information uh, in terms of the dermatology as well as some tips from my own journey of this. So before, when we, as dermatologists, a long time when PCOD was not that much common and it was confused with so many things. There was no definition criteria. There was a lot of things which was related. There were not many people who had simply uh, said as PCOS or PCOD, just having some symptoms, not clearly, difficulty in management. At that time, dermatologist role was just referral based. We would either get referral from the gynecologist or from the dermatologist, and we would cases which were coming up with need to see more of it. So we would take No, doctor. My more concern is the face. We cannot be a referral based doctor, and we have to have knowledge. Is my screen properly visible? The slides?
Uh, Doctor, your screen share is off and your voice is not very clear, is what I'm hearing. Can you please re-screen share?
Okay. Is it now visible?
Not yet, doctor. We can't see your screen.
No.
Not yet.
Give me a minute. I'm getting an issue here a bit. It's not. Is it visible now?
Yes, doctor. Yes, doctor. It's visible now. Yeah.
Yeah.
Yes.
So when we realized that a dermatologist has to have a good knowledge of PCOD as well as learn to manage the other part, not just the dermatological symptoms. And that is when the major role of dermatologists came in. And we started including PCOD in all our lectures, in all our conferences as a major topic, because this comprises of nearly, I would say, 5% of or 10% of our daily OPDs. So today, I begin with that topic, dermatology in PCOD. What I've done is I've tried to divide and simplify it into 4 topics, and all these as a dermatological perspective. So introduction, a little bit of pathogenesis, because without that it is a bit difficult to understand the dermatological symptoms. So simplified it a bit, but I'll explain. Then the symptoms and the prevalence of the dermatological symptoms in PCOD, and a bit on management issue. So introduction. Now we already know that polycystic ovarian syndrome or Steen-Leventhal syndrome, these are the people who found out what the polycystic ovarian disease is, the commonest endocrinological disorder in women of childbearing age group, leading to reproductive as well as metabolic dysfunction. And more of metabolic dysfunctions are the ones which produces the dermatological signs and symptoms. Now we have this diagnostic criteria now, and it's much clear about the metabolic resistance or hormonal imbalance or are actually PCOD cases. So only women that fit into this criteria we do include in the management of PCOS now. So what needs to be there is oligo-ovulation and or anovulation. Now, oligo-ovulation is menses per year. Then we need clinical hypoandrogenism and or biochemical signs of the hyperandrogenism being hormone, the in PCOD, we found it to be elevated. So clinical hyperandrogenism symptoms, whereas the lab polycystic ovaries, though it is said as polycystic, it's usually a misnomer. There are no cysts. It's a misnomer. misconception among the patients usually that I have big cyst in my ovaries, which isn't true. But we include here the follicles basically, which are there in the ovary. So more than equal to 12 follicles in each ovary, measuring about 2 to 9 millimeter in diameter, and or increase ovarian volume more than 10 ml. So this is what by ultrasonography we uh, take it as a criteria. So coming to the okay, coming to the multifactorial etiology or etiopathogenesis of PCOD, there are a number of factors that are taking part, taking a role of theirs in PCOD, which includes some genetics, epigenetics, obesity. Nowadays, obesity is not very much considered because we're seeing more of lean PCOS cases also. Sedentary lifestyle, a important factor in the etiology, and certain environment factors like we have what we are eating, the dietary pattern, our lifestyle also comes into the play. So all these factors together or individually, they do two things. One is that, and secondly, they cause a certain dysfunction in the ovary. Also, a little bit of dysregulated hypothalamo-pituitary axis. Now, by that I mean that the hypothalamo-pituitary axis is the one that governs our full endocrinology or hormonal balance. All these three things will be a little bit imbalanced in case of PCOS. All of this will produce a bit of excess of androgen excess or hyperandrogenism, which is going to manifest as the symptoms in the patients. So we have the dermatological symptoms, which I'm going to be discussing now. Non-dermatological, more of gynecology, which have already been discussed with you all. And a long-term morbidities like type 2 diabetes mellitus or endometrial hyperplasia and cancer. And also a major part about psychiatric disorders. So this is in short about the etiopathogenesis of PCOD. The symptoms of PCOS, so I've included non-dermatological like obesity, menstrual irregularities, infertility because there are many patients coming with infertility and then linking it to the PCOD or then getting detected. Risk of developing type 2 diabetes mellitus and associated thyroid problems. Now, dermatological, we have mainly acne, hirsutism, acanthosis nigricans, female pattern alopecia, seborrhea, striae discensea, and acropodoms. Now, I would be discussing this on individual basis. These are few of and the commoner ones that we see on daily basis. The prevalence of dermatological symptoms in PCOS. Now, how much do we see all these symptoms on daily basis or in the PCOD patient? What is more commoner that we see? So, hirsutism is one of the major complaint that we see. Next is acne. Female pattern hair loss and acne most of the time go together. Acanthosis is another one which we see mostly in obese PCOS and not much in the lean PCOS. Seborrhea, I'll be explaining to you what is seborrhea. That follows next. Striae and acropodons. These are also the complaints which are associated, not very much consultation seeking complaints, but usually when we take the history, when we examine the patients, we also find these associated with them. So coming to the first one is the hirsutism or the excessive growth of the hair. This is the most distressing and the dermatology consultation seeking implication of PCOS. It is an terminal hair at androgen dependent areas in females, which are very much similar to the male distribution. So what this means is the growth of the hair, and by terminal hair I mean that a thick type of hair, because usually even the females at androgen dependent areas, which are usually the beard, the chin area, mustache area, we have few of the hair, or every female will have some hair or the other, but they are in terms of villous hair or a fine thin baby hair. But what we see in hirsutism is a terminal hair, which is a thicker growth as in males. So which are the sites that are involved here? Upper lip, chin, upper back, lower back, upper abdomen, lower abdomen, arms, and thighs. Now, when we see a patient with hirsutism or excessive growth of terminal hair, we need to grade it because that tells us whether the person goes into or fits into the criteria of PCOD, or should we investigate the patient a little further to actually find out, even if the patient is not giving us any history of irregular menses or associated complaints. So we come to this modified Ferriman-Gorley score. Now, this score is actually very subjective, but very helpful in evaluating and quantifying the growth. So it depends upon the examiner. There is a range from 0 to about 4, which is given for each of the site involving the hair growth, and it's counted, added, and then a total score is taken. Now, in terms of PCOD, if the total score goes more than 8, then we consider the patient being falling into the criteria and we can investigate further. The score ranges from 0 to 4, that is for individual site, that is no hair, extremely terminal hair. So that is how I said very subjective as per the examiner, because there is no definition between a villous hair or something in between and the terminal hair. But useful, very much helpful. So the modified Ferriman-Gorley score is what we use to grade the person. Now this I put a picture. So this is a picture showing the excessive hair, the typical side locks everyone have. But if you see the side locks, the hair there are not villous hair or not baby hair or not fine hair. They are very much terminal hair, very much like your axillary hairs, or similar to your scalp hair, so thicker in diameter. So this is a case of hirsutism. You can see the involvement of the jawline and the chin area with thicker hair. PCOS is there is increased activity of this enzyme, which is called as 5-reductase enzyme. Now this enzyme is required to convert the testosterone or the main hormone into its active metabolite. So since there is increase in the activity in the androgen dependent sites, there is alteration of the hair cycle resulting in the transformation of the villous hair into the terminal hair. As I already told you, they are thicker and the darker. So coming to the next topic, we all know acne or pimples, how at least all of us might have had it at least once in our lifetime. So usually as acne, I don't even regard it as a disease because it's a lifestyle problem or a general puberty problem. Now, acne is a condition that occurs when hair follicle becomes plugged with oil and dead skin cells. The next picture, I would like to explain the various stages of how we see acne. So we see it as microcomeron, one that is called as a
Dr. Agnita, can you please repeat?
there
There
is
was a disturbance.
corneocytes or hair follicles or dead skin cells which plug the hair, top of the hair follicle. Before that, you couldn't. Should I start only with explaining the picture?
Yes, yes, please do. We were not able to hear in between. That's it. Now it's fine.
Okay, okay. So this is the picture explaining the various stages or various presentation at different levels of acne. So the first thing what we see is a microcomedon. Microcomedon is just like a whitehead in local language, but they are closed. They are not open. So if you express it, there is nothing that you can get. So why you get it is because there's a plug kind of an plug of these dead skin cells which is there in the hair follicle, closing it. The next stage is a comedon or blackhead. Now, why from whitehead it turns to blackhead is because there is accumulation of this shared corneocytes and sebum and a slight dilation of the follicular ostium. Now, that means the hair opening gets dilated. Now, because the contents are exposed to the air, the contents of the white comedon are exposed to the air, they irritate all the women and we keep expressing it. But this is the second stage, how we see them. The third stage is these black comedons or the white comedons, microcomedon, comedon, both, they tend to get inflamed. Inflamed, why? Because there is a proliferation of propionibacterium acnes, which we have as a normal flora on the skin of the face, and it tends to go into the follicular unit, cause infection, and then inflame. So this is what you see as a papule or a pustule or what you call the normal bump on your face. The fourth stage of the inflammation, there is a rupture of the follicular wall inside, which leads to marked perifollicular inflammation. That means because of the rupture, because the leaking of the contents, the skin throws up an excessive inflammation at that site, and it would be appear like a tensed-inch hard nodule inside your skin. Now, the reason why I explained this is because I wanted to differentiate the normal acne that we are seeing and the acne that we are seeing in the PCOS patient. Now, what we are seeing in the PCOS patient is a nodular one, the last grade. And these three things, though they are present in certain aspects, but not that would alarm me as a PCOS patient, as an acne in PCOS patient. So going to the next one, this is a hormonal acne or acne in PCOD. Now here you can, in this picture, you can see all the types of the acne. You can see a nodular one. You can see the black comedons present. You can see the nodule there. You can see a pustule there. You can see on the jawline, you can see there is a line going into forming sinuses. Now that is a stage where the nodules break open inside and join themselves, forming the sinuses. So this patient has all. And as I said, it's not the one thing that will alarm me in diagnosing PCOD, but as a combination, a picture of everything will, help me diagnose it. Now, how do we differentiate the hormonal acne from the normal acne? Normal acne is the one that we see in a pre-pubertal or pubertal stage, or what we call acne vulgaris, not having any hormonal involvement. Now, in hormonal acne, we predominantly find involvement of jawline, chin, neck, and chest. This is what I showed you. There was an involvement of the jawline, chin, and in her, there was involvement of the jawline and neck. Also of the chest, more commonly. New onset adult of acne is another One thing that alarms me about PCOD, the a patient, a female patient who never had acne, who doesn't have a genetic predisposition to acne, suddenly comes with saying, "I have got breakouts, and these are the acne lesions that I got suddenly." Yes, could be a hormonal acne. Third is a nodulocystic variant of acne. Now, this is the fourth grade of acne, a severe one with or without the menstrual irregularities and hirsutism, that means with or without other signs of hyperandrogenism, is a it's not the criteria, but very much pathognomic of hormonal acne. Premenstrual acne. Now, premenstrual acne can be a flare up during the premenstrual period, or developing only during the, though although the all the normal acne have some bit of premenstrual flare up, but in these cases it's very much well defined that the patient would come up and say that I am getting acne only before my periods. It starts about 2 to 3 days, gets worsened, and then remits even if I don't do anything. So that kind of a premenstrual acne. Cyclical flares similar to premenstrual acne. That means you get the acne at one particular time in whole lot of outbursts and then remits itself, or doesn't go completely but comes down on its own. The one that is resistant to conventional treatment. Conventional treatment being the normal the patient still gets repeatedly recurrent outbreaks, then we think of patient as to find out if there is a that is playing a part.
Dr. Agnita, we are unable to view your screen. Please kindly share the screen.
Dr. Agnita has logged out by mistake. Can we have some time? We are connecting with Dr. Agnita. In the meanwhile, can I please request all the participants to be patient while we are connecting with her? It's raining heavily in Goa. That could be the reason why we are having network connectivity issues. I would request all the attendees to kindly wait. Dr. Agnita has joined back.
Could you hear me now? Can you?
Dr. Agnita, I can hear you, but I cannot see you and the screen share. Can I please have your screen share, audio and video, please? I can see you, Dr. Agnita. Can you please screen share? Yes, screen share is also visible. I would like to thank all the attendees to patiently wait for this while we are reconnecting with our webinar. Thank you all. Dr. Agnita, you can start.
Can you hear me now?
Yes.
Can the screen be seen?
Yes, doctor, we are able to see you as well as screen share is there. You can kindly start speaking.
Okay. 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 So there is some network issue because of the climate here, the rains. I'm so sorry for that. So I'll start explaining from Siboria. I think that is what we uh, missed. So there is presence of oily and greasy skin on nasolabial folds, forehead, and behind the ears. Uh, Causes being are hyperandrogenism and hyperinsulinemia, the hormone excess as well as the insulin resistance. Now, in addition, patients' genetic composition, climate, and emotional factors are also found to be responsible for seborrhea. So we don't see patients with seborrhea because nobody comes with the oily, greasy skin unless and until it is very much unbearable. Sometimes in Goa, with the humidity being high, we do see when patients are having trouble cleaning their face all the time. But there is a disease or the identity that is caused by this oily and greasy skin, which is called as seborrheic dermatitis. Now, we do see a lot of patients with seborrheic dermatitis, which is a flaky condition that causes scaly patches and red skin and stubborn dandruff, a very difficult to treat dandruff. Now, or not all the patients of seborrheic dermatitis are grouped as PCOD, but the ones that have, in addition to the borea and the other acne or other dermatological symptoms of PCOD or any other obesity or irregular menses, we do investigate them. This is one of the problems that we consider. Now, what is the cause of seborrheic dermatitis? That means the seborrhea skin or the oily and greasy skin present goes into a dermatitis because of a presence of a fungus which is known as Malassezia fungus. Now, this is present on the skin, only turns pathogenic when the oily and the greasy skin gets irritated with it. Okay. Next, we come to female pattern alopecia. Now, this is also a very, very important aspect that we see. We get a lot of patients with female pattern alopecia. Am I visible?
Yes, doctor, we can see you.
Yeah.
Yes.
Okay. Um, so female pattern alopecia, it is characterized by progressive loss of hair or thinning at the vertex or the crown area. Now, in these typical female pattern alopecia patients, the frontal hairline is preserved, not like the males. The frontal hairline in females is preserved, and they also bitemporal recession, which will be hair loss at the temples, is does occur, but not very common as in male pattern alopecia or androgenetic alopecia. Now, the female pattern alopecia, in terms of the hormonal loss of hair, we do see something like androgenetic alopecia as in the males. So, the similar pattern that happens in the males, we also see in the females, as well as this term which is called as female pattern alopecia. So, both of this are considered as hormonal alopecia. So in PCOS, the testosterone and the dihydrotestosterone, which is the active variant, will shorten the emergent phase of the scalp. Now, the same emergent phase, which by these two hormones at the androgen sensitive sites, like the beard and the chin, when we're speaking about the hirsutism, the same emergent phase is increased. Whereas in the scalp region, the same emergent phase is shortened, and that is what results in a pattern alopecia. So this is a case of classical case of female pattern alopecia. As you can see, it's the thinning of the crown area as compared to the rest of the sides, the occipital as well as the parietal side, the hair growth is preserved. Also, the frontal hairline is preserved, but just the thinning of the crown area. So this is a very, very common picture we see all the time. There is no bitemporal recession, what I'm talking about. The androgenetic alopecia that in males have this kind of loss of hair from the temples is not there here. But that is also another presentation that we come across very often. Coming to the next is Acanthosis nigricans. Now, Acanthosis nigricans is characterized by a brown, velvety, moist, varicose hyperpigmentation of the skin. By hyperpigmentation of the skin, I mean discoloration or a darker discoloration of the skin. So it's very much brownish or blackish, sometimes grayish also. It's velvety kind of a pigmentation, like a thick layer is present, moist, and varicose means it's irregular surface, not flat. So the sites involved here are back of the neck, which is very, very common, armpits, groins, underneath breast, and inside of the thighs. In more severe cases, we also see facial involvement and involvement of the extremities. Like there's pigmentation over the forehead, over the face, which is regarded as a normal, but when we carefully examine with the hand lens, and we see it, we see a thin layer of velvety, moist kind of a layer. So that is regarded as a facial acanthosis. Also of the extremities, some acanthotic patches of the extremities are seen, but this is in more severe cases or probably a long-term acanthosis, neglected acanthosis. So why this happens is it is due to the excessive binding of insulin to these growth factor receptors, which result in the proliferation of keratinocytes and the fibroblast. Now, the keratinocytes and the fibroblast are the cells, the skin cells, which go on proliferating and form a thick layer. And also the melanocytes, the color cells are increased. That gives us a brown pigmentation of it. Now, there's a picture. This is a case of yeah. So this is a case of milder version of acanthosis. As you can see, what I was talking to you about, it's the neck of the, it's a back of the neck. So there is a slight kind of black velvety layer that you can see with the hyperpigmentation and the normal skin in between. Which, this would make you uh, understand what I'm talking about, the kind of pigmentation. It forms a thick layer. Now, to tell you few things about acanthosis, this is what we see mostly in obesity, in obese PCOD, PCOS patients. This is what we are seeing in young PCOS patients. This is something like the first thing that we preserve with, that my baby was not born like this, but now she's developing this lot of pigmentation. Her neck is getting pigmented. They tend to rub into it and make it move worse. So this is a kind of a symptom that I see more among the young PCOD cases. These are the last ones, that is striae and acrocodons. Acrocodons are the normal skin tags, and striae is like the stretch mark. Now, this happens because of the obesity as well as the hormones produced also stretch the skin up and give you the striae. Usually, acrocodons are considered to be a part of the life. It is not considered, like patients do not come with that unless and until they're cosmetically they're causing cosmetic disfigurement in the patient. So these can also be part of the PCOS. Coming to the management, and I've included this from a dermatological perspective, that patients with these symptoms that I've explained come to me, and then what is my role in it? So when it comes, and when I am particularly thinking about that this patient can go into or can be a PCOS patient, and I need to investigate further, then I do something called a hormonal assay. Now, hormonal assay, the important hormones that are required is a follicular stimulating hormone and the luteinizing hormone. Also, free testosterone, which is very much important nowadays because it is very much elevated in 70% of the PCOS women. Now, the follicular stimulating, I won't go into the details of what it causes, but why we do it and how we classify it is what I like to tell you. So, these follicular stimulating and the luteinizing hormones are done because the luteinizing hormone is slightly raised in the PCOD patients. We also do a ratio, which is LH to FSH ratio. So, whatever is the count with the LH and the FSH is divided, and we get a ratio. So, if it is more than equal to 2, it is very pathognomic of PCOS, but not diagnostic. We cannot say that yes, your ratio is high and you are PCOS, definitely. No. but this is very much telling us that we are seeing the person going into an hormonal imbalance. Free testosterone is elevated in 70%, like I told you. Uh, Now, the important thing is that, and what people don't know is that we need to do these tests early in the morning and preferably between the day 4 and day 10 of the menstrual cycle. Though there are various studies saying it is not important, and the ranges in the hormonal assay are also given as per the stage, but this is the most sensitive and most clear indicator, I would say. So that is what we do: an early morning sample or a fasting sample, and between the day 4 and day 10 of the menstrual cycle. Some people like to do it during the menstruation also. That is another clear indicator because we get a range properly. So other test or the other hormonal test that we do is DRS. Now these tests are not to detect PCOS but to separate it or to detect some other variant or to exclude the some other variants. Like we do DIS to just to identify because there are no other internal causes which are producing high androgen in the patient. TCH, thyroid, like I told you, thyroid coexists with PCOS patients, so we need to do that. Prolactin is another kind of hormone which is raised. Biochemical analysis. Now, in biochemical analysis, there are certain things that are raised or found to be associated because there is insulin resistance in the PCOS patients, which produces a metabolic resistance state and lead to fasting glucose, the high glucose or sugars in the patient. So we need to rule out the long-term morbidities, and that is why we do fasting glucose, fasting insulin to identify the insulin resistance, serum lipids, because there is more of hyperlipidemia, the raised, and oral glucose tolerance test. Now, oral glucose tolerance test is not done in all the patients, but certain patients who are prone or who come with the symptoms, probably with a history of diabetes, with a history of gestational diabetes, like during their pregnancy. These are some of the patients whom we consider for oral glucose tolerance test. It's not something that we usually do. Lastly, pelvic ultrasonography to detect the cyst and the ovarian volume that is required for the criteria. Then comes to treatment. Now, treatment are divided into lifestyle modification, the local therapy, systemic therapy, and psychological support. Now, why I didn't go for treatment at the individual aspects when I was discussing acne, the treatment of acne and hirsutism is there is a reason for it, and we have to realize that PCOS cannot be managed individually. We have to have all these four things managed. No tubes can relieve hormonal acne. So we have to understand that we have to do certain amount of lifestyle modification, certain local therapies that would be given, certain oral therapies or the systemic, the ones that for the pathogenesis that we have to do, and also very importantly, psychological support is needed. So all these things together can achieve a good state. Lifestyle modification. Now, this is the cornerstone treatment of PCOS, and every dermatologist must spend some time in explaining this to the patient. I do feel it's of very important because usually we just treat the symptoms and the patient goes home, applies the tubes, come back to us every time or changes the doctor thinking that I'm not benefited by it. But what is not being explained or counseled to the patient is the lifestyle changes which have to be done with the prescription that is given. Now, this is needed for overall balance of the PCOS. So certain few points that I've included, not much, is exercise. WHO recommends about 150 minutes of exercise, vigorous or moderate physical exercise per week. and also increase in the activity as a major. The activity is very much different from exercise. Is exercise what you train your muscles or get into something. Activity generally that we don't go to pick up the glass, or we just have this Alexa and Nico dots and all of this. So we say play this, play that. Now even the we don't even get up for putting the fan on. So these are the things what we need to do it in a little bit of increased activity. Maybe, sweeping your room, and this was told to me by a doctor. So you just need to sweep your room. Do not call the maid. You just do it by your self and see the improvement. So this is the increase in the activity that I'm talking about. Diet. Now, in diet, and when every PCOS patient is being told that you have to lose weight, and patients go on intermittent fasting or on some dieting, reduce that, and go on a very, very starvation mode. So that's not what is recommended, because it is going to make PCOS all the more worse. So what is recommended is no intermittent fasting, no skipping meals. Rather, you have to have 4 to 5 meals or snacks per day. Now, when I mean this, it's not about increasing the meals or snacks, but just dividing your 3 meals into 4 to 5 meals. So the quantity or the amount would be same, but divide it into the 4 to 5 meals. So short snacking or short meals at the regular intervals. More of protein in the diet, that helps. Third thing is sleep. Now, sleep is not so given importance, but yes, when we come to the dermatological symptom, we realize it is really the beauty sleep that we need. So you have to follow sleep hygiene by having regular bed and wake up timings, avoid daytime napping of more than 30 minutes, and avoid bedtime technology use. Now, coming to the local treatment as per the individual disease. Now, for hirsutism, and this is what I've included more in a broader aspect than the other diseases. So here in hirsutism, we have temporary measures like plucking, waxing, threading, shaving, bleaching. This is what we tell the patients who do not want to go for any kind of permanent procedures. They may be having a milder symptom and can be managed with this. But these are not the long-term solutions, but a temporary kind of a measure if the patients do not want to go for permanent ones. Now, permanent ones would be medical and the lasers. And when I say medical treatment is permanent, I would like to explain to you what is the medical treatment of hirsutism. Not many people know that for excessive hair growth, there are tubes that are available. Now, here the tubes that have come, the drugs have come and are available in the market are two of them, eflornithine and Curidil. Curidil is a very newer topical gel, not widely available. Eflornithine is there in the market for a long time. Now, what it does is it causes a bit of miniaturization of the hair follicle, and we do see a hair reduction up to 70% also in continuous usage of about 8 weeks. But it is reversible. And secondly, we have to counsel the patient that this is not a measure to be which can be used solely. So usually these medical treatment or the tubes that are available are combined with the lasers and not only used as a single measure. But yes, in setup where the lasers are not available or in patients where they're unaffordable, we do give this as an option. It's not that you have to resort to the temporary measures, plucking, waxing with the medical measures can give you some relief. But if at all used continuously, I'm saying it again, use continuously for about 8 weeks and then continue to maintain, because the mere stopping of the drug can reverse the aspect. Okay. Then coming to the lasers. Now here, the mechanism of action is a focal thermolysis that the lasers do. There's a focal damage of the hair follicle that the lasers cause without destroying the adjacent tissues. Now, it also induces a miniaturization of the terminal hair into villus hair. That means some of the terminal hair would be brought down to the villus stage or the baby hair stage, which are not so black, not so thicker, maybe fine brown hair, and which cannot be visible, which are not that much visible and disfigured. Now, I've not reviewed the gross theory of lasers, but there are various types of lasers that are available, and that depends upon the light sources like red light, infrared, electron light, diode lasers, and there are a couple of them, different brands, different marketing. Many of them are available. Um, they all do the same thing, but the hair growth reduction depends upon the type of the laser that has been used. Now here, the few important points that I would be, I'd like to share with you all is that multiple sittings at regular intervals are required. So it doesn't happen in one shot. What some people think that you just can get a laser and can get the hair reduction in one sitting. No, it doesn't happen. And the first sitting is very much unpredictable. So we need to counsel that there are multiple sittings at regular intervals needed. Now, with a good diode laser, this is with a good diode laser, not with every laser, there is amount of 65 to 75% of the hair reduction which is possible at about 3 months after 1 to 2 sittings, whereas more than 75% reduction can occur in a 8-month period. Again, depends upon certain factors. More effective in fairer skin than darker. So lasers are, because the melanocytes are the ones interfering with the laser light, uh, also more effective in fairer skin than the darker skin. Now, hormonal profile need to be monitored. Now, here what I would like to tell the people who are planning to go for laser or thinking of laser for the hair removal is that what you need to know is there is a whole counseling session that is required. Now, what we need to understand is there cannot be an inside pathology, ongoing inside pathology, which is going on, and just for the cosmetic improvement, you would go for the laser. That can rebound back, like after the stopping of the laser, you can get the hair back. That is because we not do anything for the inside pathology. So, lasers cannot be used as a sole measure. It has to be compiled with the medical treatment for PCOS. Again, even while doing the lasers, we need at various time to do the hormonal profiles or the hormonal assays again and again. Now that depends upon the dermatologist who is doing the laser as per the grade of improvement, whether the patient is improving, whether the patient is developing new hair, or the laser is not responding very well. So we need to do hormonal profile in between a couple of times. Now, do not have unrealistic expectations out of this. It's a procedure. It's all mechanics. It differs, and I feel it is better for a patient to know about the laser prior even meeting the doctor for it. So you have an idea about how it works. You have to have idea about, and now there are a couple of demonstrations on YouTube, so you get to know how it is going to work. You get to know the procedure by looking at the video. So get to know yourself about the laser. Second thing, what you need to do is when you go to a doctor, please sit with the doctor and get a blueprint of what the treatment or what the procedure is going to be like. So you and the doctor need to decide, not just because your friend had a growth reduction just in the two sitting, you would have that. So no, every patient is different, every laser is different, every doctor is different. So both of you need to sit and have a blueprint. So in that way, you're kept more grounded to the treatment. Otherwise, there's a gap between the expectation of the patient and the results that is being provided. Patients don't know. Sometimes when the results would have happened, the patients drop out. So we actually need to know about it. So if you know about it, you would be more grounded. You would know what would happen next. So more of counseling sessions are required prior to the lasers. Now, coming to the next is about acne. For acne, we usually start with giving conventional treatments and then proceed to the oral or systemic therapy. And that is in terms when the patient is not responding, basically. So, the most basic treatment would be giving them topical creams or gels, antibacterial gels like clindamycin, metronidazole are the first line therapy. Benzyl peroxide is excellent drug which works. So combination of these retinoids and salicylic acid gel, the retinoids tend to increase the follicular pathways. So the blocking of the or the comedone development doesn't take place much. So we need to combine this as per the symptom. Now there is this chemical peeling which is available, and chemical peeling is used as a supplementary therapy and not the sole therapy for acne. In terms when the patient wants faster results, probably there are certain issues with the hyperpigmentation that we're looking along with the acne. So there are various chemical peeling are available, giving us a beautiful results like glycolic, salicylic, azelaic, mandelic acids. These are fruit acids used in varied concentrations and differs in terms of the patient, how we use it and when we use it. Systemic therapy available, and in systemic therapy we include the oral antibiotics for the propionibacterium as well as the isotretinoin. Isotretinoin is a wonderful drug. It is oral retinol. But in case of PCOS, what happens is there is group of reproductive age group that we see, and on isotretinoin it is not advisable to conceive. So usually we see a patient who's seeing the gynecologist for the infertility and the acne is erupting here. So in those patients it finds a very low, or we just cannot give them isotretinoin. Third would be alopecia. Now, in alopecia, the topical minoxidil is the first drug of choice. We give it with supplements, something like the stimulators, procapil, capaxil-based lotions are given, which are like the vasodilators. Oral finasteride. Now, this finasteride is the drug that blocks the 5-alpha reductase enzyme. Can be given in women also. But a long-term therapy is required for female pattern alopecia or any kind of endogenetic alopecia because the moment you stop it, it goes back. So what we do is we usually start with something a little stronger, titrate it in between, and then use a maintenance lotion for the rest of the time. So you need to have a lot of patience with alopecia treatment. Now, acanthosis nigricans. Now, this particular identity responds very low to the treatment, and you hardly see any improvement with just depigmenting or lightening agents that we use. It has to be combined with the lifestyle modification, and also in some cases oral metformin is available. So oral metformin or the insulin sensitizers, we can use them because they decrease insulin resistance, which is uh, the main cause of acanthosis nigricans. But it has to be used on a long time period. Then Seborrhea. Seborrhea is the oily and greasy skin, so to reduce it, we use some salicylic or glycolic-based face wash. And if the patient is suffering from seborrheic dermatitis, then we use anti-dandruff shampoos, salicylic-based or antifungal like ketoconazole-based, sometimes coal tar-based shampoos to reduce the dandruff. Now, when I come to the systemic therapy, this is more of the treatment of the gynecological part, but how we use it in terms of for the dermatological symptoms, to manage dermatological symptoms. I'm not included it as a whole, but just a few aspects to how we use them. So some patients get shocked when we prescribe them OCTs, but these are also linked on how we manage the symptoms. So what do OCTs do is it decreases the ovarian androgen production and reduces the free testosterone levels. So hence they are prescribed in acne. Now when it is prescribed in acne is when the patient does not respond to the conventional therapy. And like I told you, my more common choice of drug would be the isotretinoin. When a patient comes with acne and women bearing, childbearing age group and already trying to conceive age group, I do not prescribe them on isotretinoin, and I have to stick to other conventional therapy. In them, I would like to prescribe the oral contraceptive pills for a set duration, get the control of acne, and then go for the fertility issues. So this is sometimes we do. This is sometimes indicated by the fertility specialist treating infertility. And this is how we manage together. Um, Then also for hirsutism, when we do the hormonal assays and we sometimes not find much of the response to the lasers, then we add the oral contraceptive pills with the lasers to get better improvement, to get faster improvement. Now, what among the old oral contraceptive pills have these progesterone? They have androgenic properties. So, what are androgenic properties is that they produce some amount of androgen, which can make PCOS worse because they already have hypoandrogenism. So, because these progestins are testosterone derivatives, what is required here is a continuous use for at least 6 to 9 months. Now, however, there is worsening of the insulin resistance and these lipidemias that we see on usage of the oral contraceptive pills for a long-term duration, not for a short term. Coming to the anti-androgens, these are the agents that directly block the androgenic action by either acting on the androgen itself or by acting on the enzymes or acting on the receptors. Now, they are the most commonly used by us is spironolactone. It's a most effective anti-androgen, also given in hirsutism, acne, alopecia. More commonly, I would say in acne and alopecia. It is also given in combination with oral contraceptive pills as it causes a dose-related menstrual irregularity. Although I prescribed much of spironolactone, never got a dose-related menstrual irregularity as a side effect. But we do sometimes get, so we do prescribe it in combination. Now, there is another one, and this is a newer progestin, which do not have the androgenic action, that is a cyproterone acetate, they are anti-androgen, glutamide and finasteride. Finasteride finds its place in alopecia, more of female pattern alopecia, not responding to just a topical therapy. Lastly, the insulin sensitizers, that is metformin. They are weight-reducing drugs widely used in diabetic mellitus, but we do not find the evidence of benefit in acne or hirsutism. But in my practice, I have found a lot of improvement in acanthosis cases who are having a little bit of insulin resistance, a little obese patients, menstrual irregularity. There are certain criteria I usually like to go for metformin. And when I said I got PCOS, I was detected, I was also taking this metformin and I found it very, very useful. But the usual side effects are vomiting and gastritis that causes. So we need to start it on a small dosage and then increase it to the required amount. Okay. Coming to the psychological support. Now, this is what is very much needed, and because the women, PCOS women, are having increased risk of developing the psychological and behavioral changes. That is because of the chronic nature of the disease. It also threatens their feminine identity, especially hirsutism or acne. They have a low body image, and I've got patients who were depressed because they didn't want to go out, they didn't want to socialize, and with this upcoming social media that we have, everyone wants to have a good Facebook picture. So it creates a lot of psychological impact on the patients, which we need to address when we are diagnosing the disease also. They are also associated with poor reproductive performance and the sexual problems. Now, depression, substance abuse, and smoking are few of the psychological disorders which are found in PCOS patients. I would like to conclude it with certain things that overall I feel it's a most common endocrinological disorder in women of reproductive age group. The dermatological manifestation of PCOS play a very, very significant role in diagnosing and constitute a substantial proportion of the symptoms experienced by women with this syndrome. Even when I've explained the whole of management and the treatment, I would like to say that it's said to say there is no effective treatment of PCOS as a identity, and whatever is the treatment is directed only to treat the individual symptom of the patient. What we need is a genuine need to diagnose this syndrome early so that the holistic treatment can be initiated at the earliest time by preventing the long-term morbidity, as you are seeing very, very young patients going into PCOS very early. With this, I would like to end it. Thank you. I also would like to thank the Dr. Kathleen and Dr. Monica for giving me an opportunity to speak about it. I'm very much thankful to you all. And even though we had certain disturbances, thank you for my patient listening.
Thank you, Dr. Admita. Dr. Monica is facing some technical issues, so I'll be taking over. My name is Dr. Rashmi Pawar, and I will be asking you a few questions from the attendees. So,
Okay.
yes. So one of the questions is that there is an attendee who is suffering from thyroid for 8 years, and her weight, she's having problem with her weight. What can she do to help it? She's not able to have any weight loss. She's tried many things.
See, as I say, and even though when I mentioned, it is not about the weight loss. It's very, very difficult for PCOS patients to lose weight. I do get it because they will lose weight at a certain point, and then it will just be there. It won't go beyond that. So my recommendation is, not to go behind that number. What you need to do is probably get into an exercise or a fitter activity, like maybe strength training. They reduce the fat cells, and that is one thing that I forgot to mention is that fat cells have these aromatase enzyme, and that converts the normal and hormone into the estrogen, and hyperestrogenic state and hyperandrogenic state together cause all the symptoms. So what we need to understand is burn the fat, convert them into the muscle. So it's not important, and when you convert it into muscle, you don't lose the number. Like you stand on the weighing scale, you don't lose, rather you may gain. So So there is a need to understand about the weight loss, that you don't need to meet the number. So don't go after the weight loss, but just have a healthy lifestyle, get into a routine of exercise that is suitable for you, more of strength training, and there are a couple of exercises available now which are beneficial for PCOS patients. Have a healthy lifestyle. Now, regarding thyroid problem which are associated with uh, PCOS, what happens basically is that, like I told you, all the features in one of the beginning side when I told you the etiopathogenesis, what happens is that whole hypothalamo pituitary axis is imbalanced, and hypothalamo pituitary axis also governs your thyroid hormone. So when we come to this thyroid stimulating, when we do this, majority of the patients will go into hypothyroidism. That is related to the hypothalamo pituitary axis, which is imbalanced, and not PCOS as a part. So for hypothyroidism, what you need to do is you have to take thyroxine tablet as per the dosage. Also, a lifestyle modification, de-stressing yourself, getting into a healthy lifestyle would change thyroid stimulating hormone a lot. So I have seen patients who were requiring about high dosage of thyroxine and getting to a very, very, very minimal one. So yes, when it comes to thyroid, you need to seek treatment for it because that's needed. And second, healthy lifestyle is important, but do not go after the weight loss. Don't think also that the weight loss is going to improve. Usually, this goes in a cycle. What I see. So when we tell a patient you need to lose weight to improve your PCOS, they try and do it. They try and reach certain. They come down by certain kilos, and then they go to a stable range, and no more further. Even if they put efforts, a lot of effort, no more further reduction is noticed, or a very very slow reduction is noticed, and that is when the patients are stressed. That is when the patients get into anxiety also. This in turn increases the PCOS or your thyroid profile. So do not run after my advice would be, don't run after the thyroid or don't run after the weight loss. It would just make your thyroid worse. Just get into a healthy lifestyle and take your thyroid meds. I think it should be the thing.
Thank you, doctor. Before we continue, may I ask you to please stop screen sharing?
Okay.
Thank you. Yes, yes, thank you. Thank you, doctor. The next question is how to treat hyperpigmentation around the neck or face?
Around the neck
or face?
Face.
Yes.
Okay. Now the normal hyperpigmentation differs from acanthosis, or there are a type of pigmentations that we are saying. More commonly, the hyperpigmentation around the neck is acanthosis. Like I explained to you, it's a thick velvety layer. This is one thing that responds not so good with the topical tubes that we give. Or even if we give, we cannot give the strong ones. We have to give some moderate topical depigmenting agents depending on the grade of acanthosis. But this has to be coupled with the weight loss because that improves it quite a lot. Second thing, what happens is the topical treatment or even systemic metformin which we give, oral metformin which we give, uh, uh, there is a response until the time the patient is taking the meds. At one point of time, the patient is frustrated, and it's not natural because you cannot keep applying the tubes all the time or take the medications all the time. The effect of that will reverse back. So it is very, very difficult. And if you want a permanent solution to it, weight loss is one thing that I would recommend along with the treatment. So both coupled together you get more benefits or you get more permanent reduction.
Thank you, doctor. The next question is, how safe is chemical peeling and what are the pros and cons of it?
Chemical peeling is something that have come up in the recent times, and we use it at various levels in treating many things. And even the acanthosis, we have got peels to treat the acanthosis also. Now, if you ask me how safe it is, they are the fruit acids in the right concentration, and the concentration that I'm going to use for a particular patient depends on a lot more things like the type of the skin, the type of the acne, or the grade of pigmentation that I'm seeing. The duration of the treatment. Duration will include the time that I do the pill, and also the number of the pills required will also depend upon it. Now, if you ask me, it's much safer. What I do personally in my clinic is I start with a very low grade for a short duration. And the first thing usually is not to get a good response, but just for me to understand what is the skin type of the patient, and for the patient to understand what is the chemical peeling. Now, the procedure is very much safe, but what requires is the after treatment. The skin, when we apply the fruit acids to the skin, the facial skin more so, the upper layer or the upper corner sites are dissolved, and then the raw area is exposed. What we try to aim at is dissolving the upper layer and getting the skin to stimulate a new layer, which would be fresh, free from the pigmentation, and in case of acne, not clogging together. So there won't be corneocytes clogging into the infundibulum. So repeated peeling can give you free of skin, free of comedons, or even the cyst. It will help in dissolving the cyst. The after treatment that is required, after therapy which is required, is the patient has to take care to go out in the sun. Even light, even the cooking sometimes can give them of pigmentation. So what happens is when you expose yourself to the hot sun and outside, you tend to get pigmentation because a new layer which is coming, the fresh one, will be a clean skin and more likely to get tan. So in that case, we get the side effects. So if a person has been very much counseled, is ready, and knows how to take the full patient care, it's a very safe procedure.
Thank you so much, doctor. The next question would be, what would be the treatment for thinning of hair due to hair loss, especially in the frontal areas?
Yeah, so usually what we get in the thinning of the frontal area or the crown area, hormonal aspect being one part of it, and there are certain other things that play a role like the nutrition or the lifestyle of the patient. So it needs to be in a comprehensive therapy, needs to be given to the patient. So biotin supplements is what I recommend. First line, minoxidil. What is minoxidil is basically it's a vasodilator, so it improves the dilation of the hair follicles. So the thinning to thicker transition happens. Also, the emergent phase, which is a growing phase of the hair, is lengthened. So if the growing phase remains for a long time, and the hairs which are tiny or the fine hair get time to go into the thick aspects or the terminal hair. So topical minoxidil, biotin supplements would be my first line. And if at all in resistant cases we do not show very much improvement with these minoxidil or with the basic treatment, we go for oral finasteride. As I told you, oral finasteride is a topical a drug that has 5-alpha reductase enzyme inhibition, and we do give it if we don't see the result. But in this, there is a slight amount of other hormonal imbalances that occur. So we keep it for as a last measure. But majority of the patients would improve with the basic treatment. Another thing, the long-term therapy is what is required for female pattern alopecia or any kind of hormonal alopecia. So patient needs and the response also comes very, very slowly. So we need to be patient for it.
Thank you, doctor. The next question is, why is intermittent fasting not recommended for PCOS?
The reason being that we have this, what to say, the normal hormonal balance in our body where the cortisol is high in the morning and low in the evening. That is how we feel fresh in the morning and low, we need to go back in the evening. That's the normal circadian rhythm that we have. Now, to balance this circadian rhythm, we need to give the amount of glucose for the insulin to get sensitized. Now, with the long term or intermittent fasting, or when you have a period of starvation, the body's cortisol levels, or especially the people who skip breakfast, what is going to happen is your cortisol level is high. And because there is a long term starvation, and that is when the body needs glucose, it's not being given, and the cortisol remains high. When the cortisol remains high, even throughout the time that you're fasting, it would lead to more hormonal imbalance. So that in turn stimulates your hypothalamic pituitary axis in terms of managing the starvation state, and the symptoms usually worsen. So you get the response initially because you are losing the fat cells, and you're having the maybe your period cycles or acne for certain time of duration will improve, but it's not a permanent solution. So it may worsen, but the worsening is not shown initially, it is shown in later stages because your body is trying to compensate at that time. So we do not recommend intermittent fasting or long-term starvation periods for hormonal or PCOS patients. We do not.
Thank you, doctor. Next question. For hirsutism, if you do threading and waxing as a temporary solution, does it further increase and worsen the facial hair growth?
It doesn't, and that's a myth actually, that when you thread and wax and you get more of hair. Now, the only thing that happens with threading and waxing, not waxing so common, but with plucking, threading, in these conditions, what happens is because of the continuous damage to the hair follicle, the villus hair, because we have in hirsutism, we have a hair in combination of at various stages. The villus hair, the baby hair are also present, the intermediate hair are also present, and the terminal hair are also present. And while doing the plucking or the threading therapy, all the hairs are removed. So there could be, because there is a damage, continuous damage or irritation that happens to the hair follicles, the villus hair or the baby hairs and the intermediate hairs, the two types of the hairs which normally all the females will have, and not so visible, will turn into terminal hair. But we perceive it as new development of hair. So that sometimes happens. Yes, I would deny that, but it's not that we do get new generation of hair. Not possible. It's a myth. But this looks like it. So conversion of terminal villus hair into terminal hair is possible with the temporary measures. We do recommend such patients to go on a systemic therapy like OCT, spironolactone, to control the the inside hormonal imbalance and to go for temporary measures. So that can be done. But yes, as asked, we do see not the new growths, but just the conversion.
Thank you, doctor. The next question is biotin supplement, is it safe for consumption? And recently there's lots of over-the-counter biotin available. And would you suggest anyone?
Would you suggest? I didn't get the last part of the question.
Okay, the first part is biotin supplement consumption safe? We'll stick to that first.
Okay. Yes, it's very much safe. It is what we recommend to all the patients, and also patients who like to conceive, trying to conceive. It's safe to give. Though minoxidil we cannot give in pregnancy or trying to conceive patients, but in terms of the biotin, yes, it is safe. There are a lot of over-the-counter medicines available now, and it depends upon the concentration of the biotin that is offered. Uh, we usually recommend around 10 milligram of biotin for a patient, and it's recommended for a set period. Now, over the I don't think even if somebody purchases, I do get patients who tell me that I'm already on the supplements that I ordered from online or any store or a drugstore. Uh, it's not major concern. You can take it. It's like any other vitamin supplements. And although the it says biotin, but they're coupled with the rest of the vitamins also, so it's safe. I have never encountered anyone with maybe allergy or something like that or overdosage of it. What we need to do is take it in a regular pattern, like one a day of 10 milligram biotin for about a period of 3 months, which is most likely what we do.
Yes. So thank you so much, Agneta, doctor. We have concluded with the question answers, and I would like Dr. Parul to take over the vote of thanks, please.
Yes. Thank you, Dr. Rashmi. Good afternoon, everyone. I'm delighted to get this opportunity to present vote of thanks for today's webinar. Let me express my sincere gratitude for today's speaker, Dr. Agneta Kamath, for sharing her expertise with us and enlightening us with her knowledge. It gave us deep insights into the topic and also revealed some interesting facts. Thank you, Dr. Agneta, for making us understand the role of importance of dermatologists and management of PCOD. I hereby acknowledge IAP Central Committee for providing us this platform, as well as their technical support team for the consistent tech support. I offer my sincere thanks to IAP Women's Cell Goa team members for working tirelessly in conducting webinars on a huge scale. I also thank all the attendees for actively participating in this informative webinar. Thank you, everyone. Have a lovely Sunday.
Thank you all for attending this webinar. Thank you all. I'd like to end the session.